demonstration of the visceral liver. But before going demonstration, let us see the which we are going to see structures. First, let us come to the liver, which is wedge-shaped structure having the inferior border, which is very sharp in compared to other borders. Liver is a 5-letter word, so everything will be having 5. There are 5 borders are there, of which this border is very important, which is very sharp. Posterior superior, posterior inferior borders is the borders which we will see during the reflection of the peritoneum, and there is a right and the left border. Okay. Surfaces are also 5. This is anterior surface, right lateral surface, posterior inferior surface and superior surface. So 5 surfaces are there. Come to the anterior surface. Is the attachment of the ligament called falciform ligament coming from the umbilicus. It diverges on the 2 sides. On the right side is the coronary ligament, on the left side is the left triangular ligament. Okay. And this lower border of the short border has having the ligament called ligamentum teres hepatis, which is obliterated left umbilical vein. Okay. This is right lobe of the liver, this is left lobe of the liver, this is anatomical right lobe, this is anatomical left lobe. Okay. So this is anterior surface. Coming to the right lateral surface, which is very important from clinical point of view. This is a right lateral surface which is covered, is come in contact with the costodiaphragmatic recess and the lung. So this surface is covered by the peritoneum. This is your diaphragm, and then comes with the parietal pleura and the visceral pleura. The space between them is called costodiaphragmatic recess. Now lung extend till to the 8th rib, and the pleura extended up to the 10th rib. So the gap between these two, that is the parietal pleura and visceral pleura, this is termed as costodiaphragmatic recess. Why the right lateral surface is important clinically? Because when there is a liver biopsy to be done, then the biopsy needle to be introduced below the 8th intercostal space. It is through the lower part. This is your the 8th or 9th intercostal space. This needle is coming to the liver to have the hepatic tissue for the biopsy. So this is very important clinically. Okay. So this is the right lateral surface coming in contact with the peritoneum, diaphragm, pleura and the lung. Lung till to the 8th rib, pleura up to the 10th rib. Okay. So this is the right lateral surface. Now coming to the posterior surface and the inferior surface together, they are termed as the visceral surface. Okay. So this is posterior surface, this is the inferior surface. What is the line of demarcation? The superior surface is the surface on which the diaphragm sits and on which the heart sits. So it is separated by the diaphragm, and anterior surface is separated by the diaphragm and the anterior abdominal wall, and the superior surface is separated by the diaphragm and the heart. Okay. So the posterior superior surface comes in this is the coronary ligament, this is the coronary ligament, falciform diverge on the right side, so it's a superior coronary ligament. This is right triangular ligament, this is inferior coronary ligament bounding a space. This is called the bare space. The bare space is the space where there is no peritoneal covering, it is bare, okay, it is open. Why this is so? Because this bare area, the central tendon of the diaphragm and the fibrous pericardium, they are developed from septum transversarium. So they are inseparable, they are attached to each other. So this is called the bare area. Okay, bounded base is formed by the IVC. This is superior coronary ligament, this is inferior coronary ligament. Now this superior coronary ligament, the groove of the superior vena cava, and this is a superior border separating the superior surface from the posterior surface. Inferior coronary ligament and the caudate process, and this is the posterior inferior surface separating the posterior surface from the inferior surface. Okay. So these are the two vague borders which are because of the peritoneal reflections. Now the posterior superior surface is called the visceral surface. Why so? Because the viscerals come in contact with the liver in this surface. What are the structures coming in relation to the liver? First we see there is this is the group for the inferior vena cava. Now to hold anatomical position liver, you have to keep your hand within the inferior vena cava, that because inferior vena cava gives stability of the liver and to stay straight. So that is group for the inferior vena cava. On the left of it, this is the caudate lobe of the liver. Liver has got 5 lobes: right lobe, left lobe, caudate lobe, and one more lobe that is called radial lobes. Okay, that is on the left side, E-peasant. Now this caudate lobe has got the process. This is a caudate process on the right side between the infra vena cava and the caudate lobe, and the papillary process on the right side towards this fissure. This is for the fissure for the ligamentum venosum. This is the ductus venosus in intertendon life, that is the channel through which the blood will drain to the IVC, but afterwards this becomes the ligamentum venosum. It comes over here rounding this porta hepatis through which the 6 structures are going, the portal vein, the hepatic artery and the hepatic ducts. So, posterior to anterior relation, portal vein, hepatic artery and the hepatic duct. Hepatic duct to a bit of right and hepatic duct to the right and hepatic artery to a bit of the left. So, these structures pass through the porta hepatis. So, this is a free margin, and then this is a ligamentum venosum fissures, and this is the fossa for the area for the esophagus, gastroesophageal impression. Then comes this area, this is called the gastric area. So, this is the area which comes in relation to the posterior surface, okay, and the inferior surface comes in relation to the remaining of the pyloric surface, and where the omentally comes in relation, this is called tuber omentally, that is also present in pancreas. This is the pyloric surface, and this is the first part of duodenum. So, this is your duodenal surface. By the right of the caudate lobe, this is your the gallbladder fossa for the gallbladder. If it is hangs by mesentery, then it is a gallbladder having mesentery. So, this is a gallbladder. Then on the right angle, this is your the right colic plexure or hepatic plexure, that is your ascending colon become transverse colon. This is called the right colic plexure or the colic area. Just above and posterior to the colic area, this is your right kidney, and the right kidney above it is a suprarenal gland which comes in relation to the Bayer area. So, these are the organs comes in relation to the posterior inferior surface of the liver. So, this surface is called visceral surface. Now, let us see again. This is the esophagus, gastroesophageal junction, the esophageal surface, gastric area, pyloric area, then the duodenal area, first part of the duodenum. Then this is fossa for the gallbladder, this is the colic area, this is the renal area, this is the suprarenal area. So, this surface is having the viscera coming in contact. Now, from this surface, let us see the peritoneal reflection. The peritoneal reflection is this is the diverging fibers of the falciparum ligament, then it comes over here on the right side at the superior coronary ligament, inferior coronary ligament, comes to the groove for the infra vena cava. Groove for infra vena cava is Bayer area. Then it passes between the infra vena cava and the caudate lobe, and then encircle the caudate lobe, enters into the groove for the ligamentum venosum, encircling the porta hepatis structures, coming back, and it comes out as a posterior layer and goes to be continuous with the left triangular ligament. This is the peritoneal reflection of the liver, okay. Now, this part is your greater sac and this part is your lesser sac. The only content of lesser sac is your the caudate lobe, and here lies your foramen called the epiploic foramen, okay. So, this is your posterior inferior surface. Now, let us see from this diagram, this is the place of epiploic foramen through which this is your omental bursa on the lesser sac communicating with the hepatorenal pouch of Morrison of the greater sac. So, this is your the site through which the communication sets in with the lesser sac and greater sac. Now, where is your the hepatorenal pouch? This is your the hepatorenal pouch. It is a subhepatic space on the right side between the liver and the kidney. So, this reflection, this is your called the hepatorenal pouch of Morrison. The fluid, if surgery done, the fluid accumulates over here. Then to the right gutter, it may go to the right iliac fossa. So, drainage pipe is given into this hepatorenal pouch of Morrison. In a supine position, the fluid accumulates in this space, dependent space between the liver and the right kidney. This is called hepatorenal pouch of Morrison. This is the space through which the lesser omentum or omental bursa communicates with the epiploic foramen, okay. Now, let us come to the fissures. What are the fissures present in the liver? So, this is the 5 fissures. Let us see. This is fissure for the ligamentum venosum, fissure for the ligamentum teres hepatis, fissure for the IBC and fossa for gallbladder. And the these 4 are vertical and this is horizontal. This is called porta hepatis. It looks like the edge shape. So, 5 fissures are there accommodating ligamentum venosum, ligamentum teres hepatis, IBC and the fossa for gallbladder, and containing the porta hepatis structure in the horizontal limb, that is a portal vein, hepatic artery and hepatic duct. This is your porta hepatis which comes in your short note, okay. Now, this is the Bayer area. I told this is Bayer area. This is a base formed by the IVC, superior coronary ligament, apex by the right triangular ligament, and the this is one side by the inferior coronary ligament. This bare area developmentally belongs to the septum transversarium, other derivatives being the central tendon of diaphragm and the fibrous pericardium. So they are inseparable from each other. This is the bare area which comes as a short node. Now coming to the lesser omentum, these are the two folds of lesser omentum. The anterior is formed by the greater sac and posterior is formed by the lesser sac. So it has got two parts. This is the vertical part, gastro-hepatic part, and this is your the horizontal limb which is called the hepatoduodenal part. So let us see how it is being formed. This is your the good for the vena, this is porta hepatis. So this is your the structure connecting the liver with the stomach, so hepatogastric part, and this is the structure porta hepatis to the first part of duodenum. This is called hepatoduodenal part, which look like a vertical and this horizontal part. Lesser omentum comes as your short node. Now let us see how this lesser omentum is formed by the two. This is your this is the greater sac forming the anterior layer, and this is the lesser sac forming the posterior layer of this lesser omentum. So this is your group fissure for the, this is fissure for the ligament of venum, where the four layers are present, two layers of the greater sac and two layers of the lesser sac. And so this anterior layer is formed by the greater sac, posterior layer is formed by the lesser sac. So I told the lesser omentum has got two layers, anterior layer is derived from the greater sac, posterior layer is derived from the lesser sac. Altogether within the fissure for ligamentum venosum, four layers going in and coming out, two layers from the greater sac and two layers from the lesser sac. This is very important, okay? And this is the communication of epiphloic foramen between the greater sac and the lesser sac. This lesser sac communicates with the hepatodenal pouch or Morrison pouch on the subhepatic recess on the right side. So this communication sets in. If infection spreads from the hepatodenal pouch to the lesser sac, then infection is being trapped and you have to take precaution to treat the patient after post-operative phase having fever. So this is all about the liver from a practical point of view and clinical point of view. Other theory papers will be discussed in other classes. Okay.